Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
This episode is brought to you by Paratus, your ultimate assistant for every emergency. Built on the trusted foundation of Easy Resus, Paratus brings you intelligent search, a complete library of procedures and protocols, and Atoms, your assistant to obtain the right information when seconds count. Discover Paratus today at paratusmedical.com/emcases and be ready for anything. If you've been practicing emergency medicine for more than a decade, your approach to the febrile infant has almost certainly evolved, and appropriately so. Historically, most febrile young infants underwent routine lumbar puncture, empiric antibiotics, and admission, regardless of your initial bedside assessment. That approach undoubtedly prevented missed cases of meningitis, but it also exposed large numbers of infants to invasive LPs, unnecessary antibiotics, and hospitalization-related harm. Now, over the past decade, we've moved toward a risk stratification, biomarkers, and shared decision-making strategy while still respecting how catastrophic missed neonatal meningitis can be. Back in 2022, on episode 173, with Brett Burstein, who's going to be one of our guest experts on this podcast, and Gary Joubert, we emphasized several core principles, and I just want to review them here so that we have a basis for our discussion today. So first, while it's true that the higher the fever, the more likely a serious bacterial infection is present, for purposes of working up infants 2 months and younger for invasive bacterial infections, fever should be thought of as binary. So 38 degrees or more, or under 38 degrees Celsius, not graded by height of fever. Many infants with invasive bacterial infections never mount dramatic fevers, and some arrive afebrile at triage. A documented fever at home counts as a fever, and historically, a major pitfall is discounting a properly taken temperature at home of 38 degrees or more in an infant with a triage temperature in the normal range. Secondly, appearance can be misleading early. Well-appearing young febrile infants may still harbor bacteremia or bacterial meningitis. Immature immune responses and limited physiologic reserve often result in deceptively reassuring early examinations. For this reason, a single normal assessment should not be interpreted as evidence of low risk. Thirdly, white blood cell counts are unreliable. We kind of knew that already. And then finally, partial workups create false reassurance. So incomplete workups do not meaningfully reduce diagnostic uncertainty. Instead, they shift risk downstream. In young febrile infants, management should be intentional, either a complete evidence-based evaluation or a clearly defined low-risk pathway with appropriate observation and follow-up. All right, so that was a bit of a review of episode 173. Today, we're revisiting the framework and algorithm we outlined in episode 173 in light of a major new JAMA pooled cohort study, the largest ever analysis of febrile infants 0 to 28 days of age, which will directly inform how we can safely defer lumbar punctures and how we can take care of these kiddies. And joining me today are two leaders in this space, Dr. Nate Kuppermann, founder of PECARN and lead author of the original PECARN febrile infant rule, as well as the PECARN CT head rule, and senior author of the PECARN abdominal CT rule and the C-spine rule. What an honor to have you on EM Cases, Nate. I feel bad not having you on earlier, and it's just such a pleasure to have you.
Hey, thanks, Anton. Really great to be here.
And Brett Burstein, who you may remember from episode 173. He's a pediatric emergency physician and scientist and the first author of the 2025 JAMA study. He works in Montreal, where way back I went to school, and both my kids go to school, and I met my wife. So Montreal has a special place in my heart. Welcome back, Brett.
Thanks, Anton. Thanks for having me.
All right. Let's start off with talking a little bit about some terms that we need to kind of get out of the way so that we're all on the same page. So there's serious bacterial infection and there's invasive bacterial infection. And we really need to understand these terms so that we can have a meaningful discussion here. So traditionally, we use the term serious bacterial infection to group together urinary tract infection, bacteremia, and bacterial meningitis. But in the most recent AAP guidelines and the JAMA study we're going to dig into, there's been a shift towards the term invasive bacterial infection as opposed to serious bacterial infection. So Brett, can you just remind our listeners why this distinction matters clinically and how focusing on bacteremia and meningitis rather than lumping in UTIs changes our diagnostic priorities, particularly around lumbar puncture?
Sure, Anton. You've summed that up pretty nicely, and this definition has changed historically over the years. The oldest definitions used to include all kinds of other infections, including even osteoarticular infections, pneumonia, even acute otitis media. So by about 2000, we were really focusing on what were called the serious bacterial infections, which, as you outlined, included urinary tract infections or UTIs, and bacteremia and bacterial meningitis. By about 2015, a more uniform term and the emphasis of research really has started to focus on what we call the invasive bacterial infections, and that excludes UTIs. So really limited, as you mentioned, just to bacteremia and bacterial meningitis. And the reason for that is that we recognize that these two infections can be occult and that they are really more dangerous than urinary tract infections. We also have relatively good tests, even among febrile young infants, to be able to identify those with UTIs. The urinalysis performs very well with high sensitivity and specificity, even in this age group, to be able to identify UTIs. That's one of the important reasons for this shift, to be able to identify the most dangerous and difficult to find infections.
And you're absolutely right. We have progressed from those terms from serious bacterial infection to invasive bacterial infection. But both Brett and I would say that even that lumping is probably not sufficiently accurate because that sort of equates the two as equivalent, but they're not. Bacterial meningitis is really, that's the disease that we cannot miss because the consequences of untreated bacterial meningitis in a young febrile infant can be disastrous. Occult bacteremia in this age range is less clear. Some of these infants clear their bacteremia. Frequently, they'll just be called back because of a positive blood culture, and they'll be treated and will be fine. So even though they're both invasive, even those two infections should really be distinguished.
All right. So I guess the big question in listeners' minds is, will the study tease apart the bacterial meningitis from the bacteremia, which isn't quite as disastrous?
I think that's one of the strengths of this study is that even though we use the common definition of IBI and look at the rules, test characteristics, and performance for identifying IBI, we were able to do a rather sophisticated statistical analysis to really focus just on bacterial meningitis separately. And to do that really required a cohort of this size.
Okay, so bacterial meningitis is the big bad one. I want to kind of flip that on its head and figure out who are the low-risk kiddies. So really the PECARN rule that we're about to talk about is about identifying those low-risk kids that we do not need to do a workup on. So Nate, could you just go through for us what the inclusion criteria were and more importantly, what the exclusion criteria were for your study? In other words, how do we decide which kids are low risk?
Yeah, absolutely, Anton. And for the listeners out there, I'd like to say something that we would think would be apparent, but I need to say it anyway, is that for any prediction rule, and I like to call them prediction rules rather than decision rules, because these rules are not there to decide for you, but they're to give you the evidence to empower your decision-making, to give you the risks. So I like to call them prediction rules, but any prediction rule that we derive, validate, they should almost by definition not include sick appearing patients, because you don't need a prediction rule if a patient is really sick. You just do your thing. We create these prediction rules around patients who present diagnostic challenges, who don't look overtly sick, and they can look quite well, but we need to figure out which might be harboring an occult illness. And that's the case in the PECARN febrile infant rule. So we excluded any seriously ill appearing patient. A critically ill patient, infant, was excluded from the PECARN rule. In addition, we opted to exclude infants that would be not too common, but around whom we would not be able to come up with a definitive answer. So patients who are currently on antibiotics because, or have received antibiotics in the previous 2 days, because they could be a diagnostic challenge. Premature infants, that is, those born before 37 weeks gestation, whose immune systems are a bit different, we wouldn't have enough of those patients to be able to generalize to those. And any infant with quote unquote chronic illness, complex congenital heart disease, etc., knowing that in the first 2 months of life, there are not going to be very many infants with chronic illnesses by definition. So those were the exclusion criteria. Who we wanted to include was the relatively well-appearing febrile infant younger than 60 days, because that is the diagnostic conundrum. So that was our inclusion criteria. Now, I just want you and the listeners to note that we included infants all the way down to 0 days. It was 0 to 60 days. And we came up with the rule that was to be applied to that whole population. However, the reason that Brett and I did the current study was because about 2/3 of infants in that wide age group are actually in that second month of life. And so for us to conclude that you could apply the rule in that first month of life, we just did not have enough precision. That is, it was highly accurate, but the confidence intervals around the risk assessment were too wide for us to feel comfortable to tell our readers and listeners to apply the rule in the first month of life. So that really was what stimulated this next study that Brett and I did.
All right, so we'll have a list of the inclusion and exclusion criteria in the show notes. I love that you're calling it a prediction tool or a prediction rule. I actually don't like the term rule because I never like to play by the rules personally. But
yeah, that's a good point. And in fact, I'm just going to comment, Anton, and actually, I don't either. When I don't like anything that sounds like I am providing a clinician, telling them what to do, either as a decision or as a rule. My job, that's not my job as a researcher. My job is to create the evidence.
Prediction tool. I'm voting for prediction tool.
Exactly.
Use the
prediction tool
to apply to their clinical judgment.
Okay. I hereafter refer to any decision tool or decision rule as prediction tool. I think that is really a great way to frame it.
That's good.
Excellent. I'll be speaking to Ian Steele about that as well.
Perhaps I can also elaborate on the rule itself. So our work in this paper builds on the foundational work of that Nate's been talking about from the PECARN group. So that was originally published in 2019. And the rule itself that they derived used statistical methods to find basically the best trade-off of sensitivity and specificity. First, it identified what are the best tests to use to identify low-risk infants, and what are their thresholds, their statistically derived thresholds. And what you'll see in this study, what we're talking about is 3 tests that don't include a lumbar puncture. That is having a negative urinalysis or urine dip test, a procalcitonin of less than 0.5, or an absolute neutrophil count of less than 4,000. So in this study, you'll note that we refer to it as the updated PECARN rule. You'll start hearing us talking more about the updated PECARN rule, and that's the story of the evolution of where that name comes from and what we're referring to. So infants who are found to have a negative UA, PCT less than 0.5, or absolute neutrophil count below 4,000, those are the infants that we can call low risk for invasive bacterial infections.
The one other thing that I forgot to mention, Anton, when you were asking about the exclusion and the question to me about exclusion for the rule is that infants who are at high risk of HSV infection, they were not meant to be part of the rule because this prediction rule or prediction tool, I guess we'll call it, is really meant for serious bacterial infections. And HSV, of course, is a viral infection. And so this rule was not meant to identify those infants. So if an infant is at a significant risk for HSV, which then I guess Brett can talk about later, this rule should not be applied to them. You need to embark on the evaluation for herpes, which typically involves a lumbar puncture.
Understood. I want to dig further into HSV in a moment. I have one question about this updated rule. So again, the tool, the updated tool is just three simple things. It's a negative urinalysis, a procalcitonin of less than 0.5, and an absolute neutrophil count of less than 4,000. Beautiful, easy, simple. The question I have there is about the urinalysis. So you mentioned that a urinalysis can rule in or rule out a urinary tract infection pretty easily. However, I find it's actually not that easy sometimes. How do you, A, obtain the urine? And B, how do you interpret that urinalysis? Because at least in the adult world, there is a huge gray area when you get back a urinalysis, whether that fits with a UTI or not. Of course, the patient's symptoms come into play as well. But anyhow, for the young infant, how do you obtain a urine and how do you interpret that urinalysis? And you had mentioned a dip as well, which, so, there's a urine dip, there's a catheterized urine, there's a microscopic urine. Could you just kind of zero in on that for us for a moment?
Yeah, Anton, you could have an entire show on UTIs, especially UTIs among febrile young infants. And that definition and testing strategies have evolved also over time. So the most recent U.S. guideline from the American Academy of Pediatrics, as well as the definitions we've used in common definition in these studies, number one, has relied historically on catheter-based urine. The American guideline also does suggest that it can start with a urinary bag collection, and that if that is negative, it can be considered negative, and this is to avoid false positive culture results. Our Canadian guideline still recommends a sterile catheterization, but regardless, the test itself can be sent for a urine microscopic analysis, urine microscopy, or a simple dipstick testing. Those have been shown to both perform with high sensitivity and specificity. So when it comes to the urinalysis result itself, we would regard that the urinalysis is considered negative if it has the absence of all leukocyte esterase, the presence of no nitrites. Typically, we talk about white blood cells greater than 5 per high power field, but that is on a spun or centrifuge specimen. Our center, for example, does not centrifuge the specimen, so we take above 10 white cells per high powered field. And you'll see both those definitions in this most recent study.
And Anton, let me add something about the collection, because this is really, really important for people to understand. So in PECARN, we did a study published in Pediatrics a handful of years ago, looked at the sensitivity of the urinalysis dip or bag for UTI. And the sensitivity is extremely high and the specificity extremely high. And this is reflected in the American Academy of Pediatrics guidelines. We accept the bagged urinalysis if it is negative as the way that Brett just defined it. Now, if that urinalysis is positive, one never sends that bagged urinalysis for culture, because that's how you get the growth of a lot of contaminants. What we would do if that was positive, we would then catheterize and look at that urinalysis. If that urinalysis was clean, we would assume that's negative and we're done on the urine. But one thing really did change with the publication of the American Academy of Pediatrics guidelines is in the United States, we accept a bagged urinalysis in a young febrile infant as long as it's negative. If it's positive, then we would catheterize both to repeat the urinalysis as well as to send for culture now that you've catheterized this. But again, with the spirit of trying to do less invasive testing, and particularly in light of this very large PECARN study with many thousands of infants looking at the test characteristics of the urinalysis for UTIs.
Well, that's a game changer for me personally, because Brett, you had mentioned that in the Canadian guidelines, it's a cath urine for young infants. And I've always ordered a cath urine for young infants. But at least according to the American guidelines, it is acceptable, if not encouraged, to do a bag urine even in young infants. I'd been doing a bag urine, in toddlers, but young infants, that's a huge game changer. I didn't know that, so very good to know. And now a quick word from one of our sponsors. Are you an ER doc looking for an exciting opportunity? Cornwall Community Hospital is hiring motivated ER docs to join their dynamic team. With over 50,000 visits a year, you'll see a wide variety of pathologies in a fast-paced, supportive environment. Your colleagues and consultants are always ready and willing to back you up. Cornwall, Ontario is a hidden gem on the St. Lawrence River, offering waterfront access, outdoor activities, and a small city charm, all within an hour's drive from Ottawa and Montreal. Join the family at Cornwall Community Hospital, and once you're there, you'll never look back. For more information, please visit www.cornwallhospital.ca and click on Join Our Team, Physician Recruitment, or call 613-938-4240, extension 227. I promised that we would talk a little bit more about HSV. Your study didn't address herpes encephalitis, as you mentioned. We know that herpes encephalitis is relatively rare, but carries potentially devastating morbidity and mortality. I personally have never seen a case, or at least never knowingly seen a case. Brett, can you just tell us a bit about when you would suspect HSV encephalitis so that we know not to use the febrile infant PECARN tool in those patients?
Identification of infants with HSV is based in part on historical features, but also the physical examination. So that's important that every infant have a thorough history and physical exam. Essentially, the best study on this was conducted by Andrea Cruz. It's published in Pediatrics in 2021, and they derive a prediction tool, if you will, for identifying infants at risk of invasive HSV disease. So HSV can be either skin, eye, and mouth manifestations, that we consider that one entity, and then the two other entities are either CNS disease or disseminated HSV, and those two together are what her study looked at as invasive HSV. Those predictors that were found to be important, number one, really above all, is that infants who are ill-appearing. And so that is the same criteria as application of this PECARN rule. But if the infant is ill-appearing, this is an important determinant or risk factor for invasive HSV disease. So that is infants who are ill-appearing. Also consider a history of seizures, or if they're lethargic and irritable, altered level of consciousness. Infants with an abnormal neurologic exam, all of those should be taken as signs of ill appearance. Also important is cutaneous findings or mucosal findings, particularly any vesicular skin rash. The other clues you may have are on lab testing. So our Canadian guideline and our hospital-based protocol uses a screening test, and there's no really good screening test, but infants with disseminated disease have been found to have a transaminitis, and that is, recent studies still show that's an important predictor. There weren't enough infants who had AST and ALT testing in that Cruz study that I mentioned, so actually it's not part of the predictors of that particular study, but we do know that the infants who are sickest with HSV will have unexplained transaminitis. They may also present with thrombocytopenia, coagulopathy. That's really more in the context of the infant who's really, really unwell. The other thing, of course, to consider is the maternal or perinatal history, and if there's any presence of vesicles at the time, particularly of a primary HSV infection in mom. So asking about vesicles or genital lesions at the time of birth, that's also important. But we talk about perinatal exposures because you can have a child at home with a primary HSV gingivostomatitis running around in the house, and we know that those are also shedding HSV. So so we talk about HSV exposures both at the time of birth or mouth lesions of anyone at home in the newborn's life. So the other part, finally, is sort of the clinical course. And these infants with disseminated or CNS disease really have a sepsis-like picture. So even if they've been evaluated and initially you weren't suspecting it, if they are not improving and they have a sepsis-like presentation, it should still be something that you're considering.
The way I think about it as a clinician around HSV and this publication that we're talking about is we know with any conundrum in medicine, there's always a risk of testing and a risk of not testing. So first of all, what is the overall risk of HSV in this population overall. And it's probably on the order of around 1 in 1,000. But that's not the question that I want to know as a clinician, because Brett just described a lot of symptoms that most of these patients will have either maternal history or at least one of these symptoms that Brett has described. The question for me is, what is the risk of missing HSV if we're not doing the lumbar puncture? That is, when is the lumbar puncture the only way that you would diagnose HSV in like an infant who doesn't have any of these other risk factors, right? And the answer to that is clearly it's many fewer than 1 in 1,000. It's now we're probably talking about 1 in a few thousand. In fact, in the AAP guidelines, they talk about 15% or so of infants with HSV who present, without symptoms or something like that. So now what we're talking about by not doing the LP is a risk of missing HSV in the order of 1 in several thousand. And now that has to be counterbalanced by the risk of over-testing and over-treating of infants who don't need it. So that's the way I kind of put that together.
Okay, so not a simple topic. However, there is this prediction tool that has been published and is a pretty good one that we'll have summarized in the show notes for HSV. But just something to be aware of is that this PECARN rule does not include HSV. And really, I think the most important thing is that when we have a febrile young infant is to take that really good history, not just thinking about IBI, but also thinking about HSV. Just have that on your radar as a potential diagnosis. And I think ultimately it sounds like it's up to the admitting pediatric team to really make that decision of whether this could be HSV or not and whether to go down that pathway or not. Before we get into the biomarkers and the test characteristics of the biomarkers that were used in the study, I want to talk a little bit about just general pitfalls in assessing febrile infants. Because, if we get too lost in the weeds of testing before we've actually done a good job with our history and physical and our assessment, then it's all for nothing. Brett, could you just give us a sense of what some of the big pitfalls are in assessing these kids with fever? We've already talked a little bit about the pitfall of having the patient with a normal temperature at triage, but they have a well-documented fever at home, that you need to consider that fever at home as a fever and work them up accordingly. What are some of the other big pitfalls?
The other ones that we haven't really touched on right now, the pitfall of a suspected viral infection as the cause. And infants who present with viral symptoms or who have positive sick contacts, we know that this influences physician behavior, although probably it should not. And any studies that have looked at the impact of viral testing, we know that infants with confirmed viral illnesses do have slightly lower rates of both UTI and IBIs, but not in a way that should clinically alter our initial evaluation and assessment. The reason for that is that basically the risk of IBI still remains above about 1% in these infants, and that even though we think these are intuitive, that if there's, this is a viral illness, this probably isn't the cause. Not all viruses are probably created equal, and some probably predict lower risk of IBI than others. So for that reason, when an infant presents with viral symptoms, a history of family members who are also sick, it's important to continue to work them up in the same way. Also because some of these infants can have concomitant viral illnesses and invasive bacterial infections. So it does still happen. So it's important really to not consider that a viral illness should alter our initial approach to management.
Great point. So bottom line is viral symptoms or even confirmation of a viral cause does not rule out an invasive bacterial infection. We still need to work them up the same way.
Exactly.
So Nate, can you just walk us through the rationale for some of the biomarkers that we use in these kiddies? So in your prediction tool, there's procalcitonin and there's the absolute neutrophil count. There's also the CRP, which most of these kids will get, that also can influence our decision making. Can you just talk about those three biomarkers and particularly what each of their negative predictive values are for invasive bacterial infection?
There's 4 traditional biomarkers, and that's the white count, the ANC, the CRP, and procalcitonin. First thing I want to say is that no one biomarker by itself is good enough for eliminating the risk of invasive bacterial infection. That's point number one. The second point is that a number of investigators have shown that the white blood cell count in screening for invasive bacterial infection in this age group is no better than a coin toss. Okay, so that leaves three biomarkers: the procalcitonin, C-reactive protein, and ANC. Probably the best study that compared those three head-to-head in this population of young febrile infants was done by Dr. Milcent and published in 2016, when she compared those three biomarkers in about 2,000 young febrile infants at risk for serious bacterial infection and invasive bacterial infection. And what she found was that the procalcitonin had the best area under the curve, that it was the most accurate test, followed by the C-reactive protein, followed by the ANC. That is the order of the accuracy. And the reason that likely explains the difference between procalcitonin and C-reactive protein is that procalcitonin rises earlier after infection than does the C-reactive protein. That likely explains its better test accuracy. And perhaps we should probably leave it at that.
All right. So yeah, a lot of these kids will come in, after 2 hours of fever. And most of those kids, I imagine the ANC and the CRP are going to be normal, but their procalcitonin will probably be elevated. So that's a good thing, I think, to understand. Procalcitonin is the best. White blood cell count is the worst. ANC and CRP are somewhere in the middle. And to understand that there is a time lag for ANC and CRP, but not so much for calcitonin.
And then one thing I do want to say, because you raised the issue of duration of fever, there are some places that pay a lot of attention to how long these young febrile infants have fever. I'm a bit of a skeptic about that for two reasons. First of all, come on, let's be real. A baby's asleep at night. What parent is feeling their baby every second and can tell you exactly how long they've had their fever? And secondly, in the PECARN rules, every time we've done this, we always adjust for duration of fever, but in three categories: less than 12 hours, 12 to 24, or more than 24. And after you adjust for the biomarkers that we have discussed, duration of fever always falls out. So the patients that we miss in the PECARN rule, it wasn't because their fever was 2 hours. That just wasn't the case. And it was never found to be significantly associated with IBI by itself after adjusting for those other biomarkers.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
One very controversial area is what to do with the febrile infant 0 to 28 days when you do not have access to procalcitonin. Because as we've been talking about, if you have access to procalcitonin, you can use this febrile infant tool and you're good to go. If you only have ANC and white blood cell count and CRP, what do you do? And I think this is going to change based on where you practice. The Canadian landscape's a little bit different than the US landscape. So Brett, in Canada, what do you recommend we do when you don't have access to a procalcitonin?
As you mentioned, it is a bit controversial and the data is a little bit limited. So the recommendations that we made for the Canadian Pediatric Society, for infants 0 to 60 days, including those in the first month of life, we recommend using a rule derived by Paul Aronson. It's published in 2019. It was externally validated a few years later. That recommendation, it actually doesn't use CRP. It is a point-based system that incorporates the absolute neutrophil count, and it can be used to identify infants at low risk when PCT is unavailable. The problem with that rule is that although, again, it is safe with high sensitivity and negative predictive value, the specificity is quite low. So in fact, you'll end up working up most infants. Nathan can speak to the American approach.
I'm going to have to comment and disagree a bit with my buddy and collaborator, Brett, but Aronson's data is retrospective. And so there's two problems with that study for me to apply it in the first month of life. First of all, it's retrospective. So we have no idea how the infants look, all the problems with retrospectively gathered data. And also, that was a study of the first 2 months of life. There were not sufficient infants in that first month of life for me to feel comfortable, just like I wasn't comfortable with applying the PECARN data in that first month of life until Brett and I did this study. So given all that, in the United States, the practice is to follow the American Academy of Pediatrics guidelines. But now with these new data that Brett and I have published, you can extend using the PCT and ANC down to the start of that guideline because we now have big, robust, and precise data, but we do not have data that we are comfortable with around the use of CRP, for example, in the first month of life that is sufficiently big, robust, and precise to use that for the evaluation in the first month.
All right, so that's a bit about what to do when you do not have a procalcitonin. I think the bottom line there is that you should go by your institutional guide, whatever that is, and just be aware that it is controversial and that it may differ between your Canadian environment and your US environment. Let's get into the data from this new JAMA study. So Brett, can you just tell us a little bit more about the study design and the key outcomes of the study?
So we conducted a pooled analysis of international cohorts, bringing the total analysis to over 2,500 infants. If we think about all 2,500 infants, what we found in the rule was that there were a total of 5 missed bacteremia and no missed bacterial meningitis, leading to a negative predictive value of 99.6%. What that means is that for all IBIs, which in this case, again, were all just bacteremia, it meant that you would have to perform 2,000 lumbar punctures to identify a single case of bacterial meningitis. And actually, when you look at the confidence intervals, it could even be as high as infinity. And in all of these studies, not a single infant with bacterial meningitis was missed. A quick comment about those cases of bacteremia that were misclassified. One of them actually has clinical characteristics suggestive of being a contaminant. And if that's the case, it would only make the test characteristics even better still. So we recognize that it is not our aim to miss bacteremia, but as Nathan said at the top of the show, a delay in diagnosis of bacteremia just simply does not portend the same adverse outcome as it does for bacterial meningitis.
Fantastic. So it rules out bacterial meningitis with 100% negative predictive value. I just want to talk about those missed cases of invasive bacterial infection. So there were 5 cases you had mentioned. Were any of them serious enough that I should be worried about missing them, kind of thing?
What Brett and I are suggesting in this rule is for these infants in the first month of life who are negative by the rule, it's not that we're going to just send them home and cast them out to the wind. We would still recommend to bringing them into the hospital, but no lumbar puncture, no antibiotics, and observe overnight. Now, fortunately for bacteremia, first of all, it's unclear how risky is having bacteremia without bacterial meningitis in this age group. But to play it safe, these patients are all getting hospitalized, and over 90% of bacteremias are identified in that first 24 hours of fever. So the vast majority of those hospitalized who might have a bacteremia without bacterial meningitis, they would be identified during their hospitalization.
So that number needed to treat, or the number of LPs you need to do to prevent one missed meningitis of at least 2,000, that is a whole lot of LP harm that we're saving. So that's incredible. So I think we've established pretty well that if you use this prediction tool and you have procalcitonin, that you can comfortably forego a lumbar puncture in some of these kids. The next question that comes up is, which patients can you forego giving antibiotics to in the emergency department? Brett, can you forego giving antibiotics to these febrile young infants if they're deemed low risk according to the tool?
So, Anton, for low risk infants, what we are recommending is hospital admission for observation with no LP and no administration of antibiotics. The fear here is cases of partially treated meningitis. So the idea is to not initiate antibiotics if you've not undertaken a lumbar puncture, if there's any change in the infant's status or they deteriorate or you're concerned, or for example, if they have any positive culture that turns out to be positive in the blood or the urine, despite meeting low-risk criteria, these are infants now whom you can undertake a lumbar puncture and start empiric antibiotic treatment.
Excellent. Love it. And now a word from one of our sponsors, Paratus, the all-new emergency assistant. Paratus combines everything you loved about Easy Recess with powerful upgrades, just-in-time procedural guidance, stress-proof organization, and Atoms, the intelligent assistant that helps you find exactly what you need. Whether you're in the ER, on transport, or in the field, Paratus keeps you ready for anything. Learn more and start your free trial today at paratusmedical.com/emcases. That's PARATUS medical.com/emcases. All right, I want to talk a little bit about shared decision-making conversations that you have with parents. So it's all fine and dandy to run through an algorithm and a prediction tool and make evidence-informed decisions, but it's a whole other kettle of fish to explain your decision-making to parents who are understandably very worried about their baby. So Brett, can you just give us a sense of the shared decision-making conversation that you have with parents of, say, a term baby who's febrile at 20 days old, who fulfill the PECARN criteria of low risk for invasive bacterial infection?
Yeah, so we've done studies with families, and we know that there's nothing more anxiety-provoking for these families already very concerned about the health of their baby than there is for undergoing lumbar puncture. This is the most stressful to parents, and it's really what they most want to avoid. So when I have conversations like this with families, I've started with a detailed history and physical examination. I've performed my urine and blood testing. I've checked for inflammatory markers. The infant meets low-risk criteria, and I now tell a family, listen, we're going to keep your baby in hospital for observation, but given the data that we have right now, historically, we've always accepted no risk whatsoever for bacterial meningitis. But with more recent biomarkers and tests, we have the ability to identify very reliably which infants meet low-risk criteria, and that it would be safe for your baby who is low risk for us to admit for observation, and it would be possible not to undertake lumbar puncture. Now, families have different levels of risk tolerance, and some parents say, hey, listen, I really need to have zero risk. And for those families, it might be appropriate to proceed with a lumbar puncture. It's just my experience, though, at the bedside, and surely you've had the same experience, that for any family given this option, with the level of risk that we now know, if I tell them, I think the chances are probably somewhere around 0 out of 2,000 that this will be the outcome, we know what parents will answer in most cases. So I tell a family, I think that's a reasonable choice. We're going to admit for observation, but that, of course, if anything changes, if the baby's clinical exam changes, or if we have any surprise on the cultures, that our approach may have to change. And that's the way I engage in these conversations with families.
Nate, when you have that shared decision-making conversation with parents, do you have any tips for us?
I would just want to emphasize one particular point. And there have been several investigators that have looked at this, doing a focus group with parents. Parents will allow you to admit their babies. Parents will allow you to give antibiotics. What parents really don't want is the performance of a lumbar puncture. That is the power of this study. So I do the shared decision-making in a similar way that Brett does. But typically, if you can present now a real number, and this is what our study has allowed clinicians to do, now we can provide a real number of the risk of missed meningitis to compare to, the risk of doing the LP, and it provides the parents with a comfort zone to opt for no lumbar puncture. Because before we would just say, there's a risk of bacterial meningitis. And, we think it's something or other, but now we can say exactly what that risk is. And parents really want to avoid the lumbar puncture.
Anton, can I put that in context for 1 second? What I love is a comparison to another very well-known PECARN rule, and that's the CT head rule for blunt head trauma. That is a rule that we use to identify infants children at risk of clinically important traumatic brain injury. The outcomes of that study included death, ICU admission, neurosurgery. This is serious stuff. And when they had a negative predictive value of 99.6%, those are children who meet low-risk criteria, whom we discharge from the emergency department with reassurance and instructions to return. Here, with that same negative predictive value for the outcome of bacterial meningitis, we're not even recommending discharge home with reassurance. We're still making a recommendation for hospital admission and observation, but rather a suggestion that we probably don't need to be quite as conservative as we were in the past, simply because it's what we've always done.
All right, so wrapping up here, this paper doesn't tell us to stop worrying about febrile infants altogether. It tells us to worry better. So for the right infant, with the right biomarkers in the right system, we can now justify deferring lumbar puncture without sacrificing safety, something that would have been considered heresy a couple of decades ago. So this study moves us closer to safely doing less, without forgetting that missing bacterial meningitis can be catastrophic. So I just want to say to both of you, thank you so much, not only for participating in this podcast, but for the enormous amount of work and dedication in your entire careers to pediatric research that has made all of our lives better in the emergency department and really contributed enormously to the better care of kids in EDs across the world.
Thanks, Anton. It's been a pleasure chatting with you.
Thanks, Anton. It was great. Thanks for having me back.
If you want more high-level, practice-changing pediatric EM gold, mark your calendars for November 19th to 21st for the online International EM Cases Summit, where we'll have Peds EM Master Educator Deb Schoenberg, who you probably heard before on EM Quick Hits, and all the way from Australia, Natalie May, who's going to be joining Justin Morgenstern to give us the latest in pediatric failed airway. This year, we've also got 2 new pre-conference courses, Katie Lynn's Synapse course and Aaron Sales' CASID radiology course, plus more symposiums, plus virtual simulations. It's going to be amazing. Please make sure you're available online November 19th to 21st for the most interactive international EM conference in the world. Until next time, take it easy.